I am Marwan Cameron, and this is the Conduit. All right, y'all, it is 4 p.m. in Kitsap County, Tuesday, November 16th. It's a busy, busy day. This is podcast live number 3. Glad that you are back again to join us. And we have a really good and important show. Dr. Yaw is back with us. And he brought Dante Morehead with him today. So we're super excited about that, as men's health is paramount, especially now. And so anything that we can do to promote Black men health, then we are going to do so. So I'm not even gonna wait anymore because Dr. Yaw is here, Dante is here. Let's go ahead and bring him on in. Gentlemen, how are you doing today?
Doing well. Appreciate you having me.
Absolutely. Dr. Yaw, good to see you. How you doing, sir?
Marwan, doing great. Thank you so much for having us back. Excited to have a chat today.
Absolutely. So it was 2 weeks ago that Dr. Yaw, you came on to the Conduit. It was already a crazy day because that was voting day. And we had several gentlemen come on and a couple of the Black clergy in Kitsap County. So that was awesome to see them here. We have another leader who is not a male, but she is a powerful force in the community that rallies folks together. So I'm going to bring her in like we brought folks in last time. So let me just kind of port that over here. But Dr. Yaw, I'll have you go first and just kind of touch again on who you are and what you're about, and then Dante can give a longer synopsis on who he is and what Backpack is about.
Yeah, so I really want to focus today on giving Dante the floor. That he deserves the space. He's an incredibly talented individual, and we're so lucky to have him as part of our team. As I mentioned last time, I'm a urologist, so I'm a surgeon who treats, among many diseases, prostate cancer, and a doctor of the urinary tract, if you will, with a focus on cancer. I'm new to the Northwest, been here for about 3 years, and a big focus for me, not only from a clinical standpoint, but from a research standpoint, is trying to find ways to make sure that everything that we do is equitable. And by that, I mean finding ways to make sure that those in our communities who have been historically excluded, have been marginalized, and who are more likely to have bad outcomes when it comes to their cancers, make sure that we're taking care of those individuals. And one of those populations that has always been at the center from a prostate cancer standpoint has been Black men. So we're looking for ways to address the needs of Black men in our community. And really, as Dante will say, we're looking to build relationships and partnerships with folks in the community so that we can start to do better.
Absolutely. Thank you for that, Doc. Dante?
All right. Well, hello, of course. And again, Marwan, thanks for having me. And Dr. Nyame is too kind when he says talented, but I appreciate that. But my name is Dante. I am the community health educator and researcher for African American, African descent populations, and I'm with the Fred Hutch University of Washington Cancer Consortium. I know that's a lot of words in the title there, but I'm with the Office of Community Outreach and Engagement. And so what I do is, outreach, engagement, education, and community-based research with, communities of color and marginalized communities. And so basically the focus is on cancer health equity and education and cancer prevention, and really reaching out to the those marginalized communities and African American specific and Black African American, African descent communities, basically. And so I have the opportunity to work with Yaw closely, as he's also tied to our program here at the Office of Community Outreach and Engagement. He's faculty. So as part of some of his health equity and research and patient engagement efforts, I get to work with him on Backpack, or the Black African Descent Collaborative for Prostate Cancer Action. Now, you know why we call it Backpack. because we are just looking to really engage with the community and address some of the issues with prostate cancer in our community and why it so disproportionately affects African descent men. I mean, we are talking about higher incidence rates, higher mortality rates, things like that. And so we're just focused on really reducing these types of disparities. So that's a little bit about me and what I do. Thanks for having me. I guess personally, if since we're going to go into that a little bit, I moved here from the East Coast. I'm a North Carolina boy, originally from Chicago. I love all things Chicago sports related. I have a 5-year-old kindergartner who just tests my patience. And but overall, I'm passionate about my work, social justice, health reform, just trying to be a good husband and father, pretty much. I'm also a picky eater, as rumor would have it, but I can neither confirm nor deny that. But I'm probably one of the most pickiest eaters you've ever eaten. So that's a little bit personal about me. So again, thanks for having me here. I appreciate the opportunity.
Well, I appreciate it. And,
Mhm.
Dante, I have a question for you.
Sure.
Dr. Yaw went into quite a bit of his background, and I
Mhm.
had the benefit of meeting with him offline before he
Mhm.
came on. How do you get to your position? Like what drove you to get into equity from a
Mhm.
medical standpoint?
Mhm.
Because I think that's important for
Yeah.
Black men and folks to understand
Mhm.
pathways and options that they can do with their life.
Yeah, and for me, that is a loaded question. It's kind of a two-parter. I have my own personal medical issues where I have experienced firsthand some what I would call inequities in the healthcare field, and then I'm also from I don't want to say deep south, but where I'm from as a black man, if you want to go into science, there's not a lot of opportunity to find mentorship or to really engage in the sciences. At least not when I was coming up. And so, for me, originally I wanted to be in the lab and I couldn't do it. And so I tried to kind of sidestep my way in through healthcare. I didn't get a lot of opportunities. But while I started working in healthcare, I came across, I noticed a lot of patients of color who were either on Medicaid, Medicare, and just encountering a lot of barriers to quality access and to quality care. And then something I just kept noticing over and over. And then you combine that with the fact that I'm a scientist at heart. And then I also got sick myself, in which, I had some kidney failure. I had to, go through chemo every 2 weeks. And going through that system, combined with me actually working in healthcare, I just saw a lot of things that I wasn't comfortable with, as far as with the treatment or the feeling of being uncomfortable as a black man in a clinical setting. And so I wanted to do something that combined my love for science with my love for people. And so public health is the perfect avenue for that. And so that's what motivated me, my own issues, and seeing what I saw coming from the South. And then I met a lot of amazing physicians of color out here in the Pacific Northwest when we moved. And I got to tell you, working in a center where you are like literally down the hall from people who are working to cure cancer, that's very motivating for me. The fact that I can just go up to the fourth floor and knock on his door, it's something that just blows my mind every time. I mean, you're doing great work with the community. I can just walk up there and talk to you. So these are things that kind of motivate me. And I hope, and it really motivates me it will add to my own work someday that I hope. And so that's how I kind of got here. I decided to pursue my master's after getting a undergraduate in just straight up biology. And then I just decided to do more work for the community. And so I landed this position and I got connected with a lot of great men and women. I have a lot of people who support me in this work, and and it's a level of mentorship that I haven't experienced as much coming up, and so I'm grateful for it. And so all those factors just kind of, to make a long story short, just kind of motivate me to do the work that I do. And I have an office that really supports that work too, because so we do good work in health equity. So all these things kind of led me to this point.
Well, I can tell you that a lot of us are very appreciative
Mm-hmm.
for the both of you. I can't tell you how important it is to see someone that looks like you
Mm-hmm.
when you're seeking, whether it's mental health or physical health or mentorship. It's important, and there's
Mm-hmm.
not enough. I personally haven't experienced a lot of black male doctors. I also have a lot of health issues, uh, and so even through that journey and going through the gambit of physicians and nurses, you just don't see it. And I grew up in Seattle, so you would think,
Mm-hmm.
okay, there's a higher percentage of of Black folks there, but still, not seeing. So it's important to see. And, it's hard to articulate the feeling of you guys being here on the podcast and being able to speak to you, and it's tangible, right? And you're doing the work, passionate about it. Like it's more than just caring for the patient, right? It's caring for the person on a whole different level. So
Right.
definitely just want to say we really appreciate that for sure.
Thank you. Yeah, I appreciate it too. Like these kind of experiences I never had prior to me moving here. And I think I was in a position where you were like, I haven't seen all the Black doctors or doctors that looked like me. I didn't really meet them until I moved out here. Before then, I had maybe like two in my life that I can recall. And I'm like 41 years old. So that says a lot. And out here, I've met like 6, 7 of them. All of them are kind of good mentors to me, and that includes Black women as well. Most of them are my mentors are Black women as well too. So it's really big for me. We always stand on the shoulders of giants, and they may not know it, but I climbed up there, whether they know it or not. I remind Yaw of it all the time, because he's a good mentor to me. So yeah, I appreciate you saying those things.
Yeah, you know what? And I do need to stand corrected. I did have one physician that was at a kind of a public clinic out in Port Orchard out here, and I think he was a PA, a physician assistant. And he was awesome and took time and understand the nuance of Black men health, and so he was great. So, and that was like 15 years ago. So you kind of forget those things, but as you were speaking, it's like no, there was one, and
there was one back. Yeah, you kind of remember.
Yeah, well, and who knows? He may watch this one day and just know that he was appreciated. So that's important. Cool. But let's talk a little bit about Backpack and the initiative and what's going on.
Okay. Did you want me to start, or Yao? Did you want to go?
Sure. I'm happy to talk about it. We feel really strongly that the starting place for addressing any kind of issue when it comes to equity is at the community and patient level. And to be able to do that effectively, we have to develop relationships, and we have to be willing to listen. And I think that is the activity that we're really trying to do. Everything we do in clinical medicine and research, it always has sort of a feel to it, right? Like, it's like an experiment. But truthfully, this particular activity, to me, even though we want to do it in a rigorous and academic fashion, at the end of the day, it's about getting to know people, getting to know where they're at, and understanding what they need. Because if we can get at that ground level and really understand, how people experience prostate related health, especially prostate cancer related health, then we can really take a step back and say, okay, these are some of the tools that we may have that we can use to solve this problem. And I think when we build those relationships, not only can we say, here are the tools, but does this make sense to you, right? It continues to be bi-directional. So, what Backpack is aiming to do is create an infrastructure where there isn't one right now, which is we really don't have a platform for doing health equity research that brings all the players to the table for prostate cancer. And we're really hoping that we can, slowly but steadily develop that ability to do that, and it starts by building the relationship. So, Backpack is I think of it as a grassroots organization that's trying to do health equity research in prostate cancer. And this study that Dante is leading is the first thing that we've really set out to do, which is understand what's happening in our own community, our own backyard. And I think Dante is the perfect person to talk about this because he's been having these conversations with the men who have signed up so far. And Marwan, I just want to say thank you. We from our first podcast a couple of weeks ago, have already had men out in Kitsap County reach out.
Yeah.
And
Oh, awesome.
I know Dante is
Yeah.
scheduled to have a meeting with someone this week. So
Mhm.
we really appreciate the support.
We do. I also had 2 meetings last week as well. So we thank you for your support. I agree with everything he says with this project. It does have, it's technically research, but we look at it more as like a movement, like he said, a grassroots movement. With the work that I do, I feel that the strongest, most important way to address this problem is to bring the very community itself to the table, as he mentioned. And this is important when you're looking at disparities anyway. And this is why community-based research is important, especially in our work. I mean, research can be good on its own merit, right? Sure, it's paved with good intentions, but when we incorporate community and, the experiences of patients is what really adds the merit to it. And so we want to not only highlight the community voice, but to have it lead us as well. And I think that's the key. And while I would say that there's a growing surge, if you will, in community-based research, a lot of it looks that way on paper. But when you read the actual proposals, because I do read a lot, they're not really community engaged. And so, it's difficult to engage with the community after the fact. You want to incorporate them from the beginning. And, these are all lessons that I've learned from experience in the actual community members themselves in the Black and African American communities. The power is in these stories and these experiences. So, and Yaw is helping with this. He's been very innovative with this work. And so, when I read the proposal, I was just enamored with it. And, I think we work well together. He's technically my faculty lead, but, I admire his work. And what this organization is doing is that we are just trying to more so connect with the community. I've said it before, we don't want to really recruit. We prefer to connect. And to get these stories and these experiences from the actual men of the community is what's going to help us address some of these issues when it comes to prostate cancer.
Absolutely. So in the study, let's talk a little bit about that. So basically, you set up a phone call or a Zoom talk for about 45 to 50 minutes. Without going into what the questions are, what are you trying to get at through this experience of gathering this information?
Sure. I mean, I can start. So yeah, so the study is, community interviews, or, we connect with men ages 18 or older. And I prefer to say it's more conversational style interviews or discussions, one-on-ones, and they're confidential. And so, I can give you a vague spell to. So we ask questions like, how comfortable do you feel talking to your doctor about prostate cancer? Or what do you think some of the barriers are to getting screened? Or maybe what kinds of information would be useful to you when it comes to health education or prostate cancer? So we want to know, and for these men to express what barriers that there are to getting screened for prostate cancer, or what was their diagnosis pathway like, or who was their support system. Basically general information, or excuse me, more qualitative information surrounding their experiences when it comes to prostate health and prostate cancer. Like, what do they know? How do you feel? Where did you get your information from? What are some of the barriers? What do you think would be useful to you if you were convincing other people to get screened? And we do talk about some personal things if they choose to share. And to be honest, most men do. We try to make it very easy to talk to. We've had some great conversations. So the questions are designed to really spark discussion and to be open-minded, so that you just, you don't just give me your medical history. That's not really it. We don't really ask about it that much. We are looking for perspective and experiences that can tap into, and we just want to make it low stress. And so yes, it is about 45 to 50 minutes, but some of them we really say like 30 minutes to an hour. So, and that's pretty good, because most men are just, they're busy, or the conversations I've had, some that have been an hour, some that have been like 35 minutes. And we can do it virtually by Zoom. We can do it in phone. We can make arrangements to do it in person. I'm doing one on Friday that's in person. So we just want to make it as comfortable for people as we possibly can, because we are interested in getting to know and understand what are the community's knowledges, attitudes, and beliefs surrounding prostate cancer health and education and their treatment and screening. And so that's what we are trying to get. And I think this information can be used as an evidence-based approach to create better policies around, addressing the barriers to prostate cancer care. So it's a good study. We just really want men to share their experiences in a confidential setting, and that's the goal.
It's unfortunate is, for a
Mhm.
lot of men, that may be one of the few opportunities that they've had to share.
Right.
So I think that's really important and powerful.
Hmm.
Can you just elaborate a little bit? So
Sure.
once you gather, like, what's the time frame that you're going to gather these interviews, and
Hmm.
as you kind of put all of this together, Dr. Yaw was saying, sharing that information back out. And so what are some of the things that you're looking to do with the information? I know you kind of talked about it a little
Hmm.
bit. Can you expand on that just a little bit, and
Yeah.
how that benefits, Black men as a whole?
Yeah. Well, sure. We want to. So, as soon as we're done, and I'm sure y'all can touch on this as well, but as soon as, we're done, we plan on interviewing a certain number of men, somewhere between 30 plus. And then after that, we compile the information that we've gotten from the interviews, and we are going to highlight the main points of data, the main concerns that the men have expressed, and look for certain themes. And at some point during the study, we also have a midway check-in point where we do what's called a community check-in. So we take the information that we've got so far. We will check in with the community that has been helping us, just to kind of check in and see if we're going on the right direction. Like, hey, this is what we're doing so far. This is what we've come to know. We've come to learn about this barriers. We found a similar theme in this, and this is where we're thinking of going. Are we heading in the right direction? And then we get the green light or not from the community to say, okay, the community is going to tell us you're on the right path. And then from that point, after our midpoint check-in, we'll continue compiling the information. And then the information here is going to be used to build upon further studies that Yao is interested in as well, more larger studies that can help us really, change patient-centered outcomes when it comes to Black men and prostate cancer. We want to encourage them to get screened more. This information can be used to help build types of health education that they really respond to. We can use it to help change policy. We can use it for anything. We can use it. I've discussed using it for like training methods for providers to become more community oriented. Some men that I've spoken to in the past have had problems with bedside manner and being uncomfortable in a clinical setting. So, for example, if we do a study, and let's just say, for example, I hear a similar theme of men saying, "Oh, the doctors didn't really talk to me. Oh, I didn't really feel comfortable." So let's say we get a bunch of men that tell us that same thing. Well, there's evidence right now, right there, that we can use to probably change some policies in the clinical setting for providers to have training to really deal with patients. And then he can use that information to build on larger studies to where we can look in changing those patient-centered outcomes. So we plan on holding ourselves accountable to the community with the information that we have. And that's the purpose of a midpoint check-in. And then after we're done with the study, we're also going to disseminate the results so that everybody can see the work that we did. It's very transparent. And I think the information that we receive is going to help change the scope of, men getting involved in more PSA screening. It's going to help providers, to go through better training to help with men in the clinical setting, and maybe even provide better information so that men can understand the role of screening, and maybe even to get screened earlier. We often say we want them, for African American men, you're considered an at risk or higher risk group. We want you to start around age 45. And so perhaps if we had men screening earlier, around age 45 or even sooner at age 40, we can, probably catch a lot of these, later stage diseases. You know what I'm saying? So if we can move the needle in that direction with the information that we receive from these men, I think it's going to do a lot of good. And of course, the information we receive from this study, Yao can take that and put it into larger studies to help things on a more, on a larger scale. So I hope that answers your question.
No, no,
But that's,
it does. I think that's awesome.
okay.
And the
Yeah.
fact
Yeah, I mean,
that
I would just say,
Mm-hmm.
or I would add that everything is a building block
Mm-hmm.
or something that's planned in the future. And one of the things that's really important to me is that the community and the men that we are engaging with understand that this isn't a one-off, right? That we're
Mm-hmm.
not coming in, going to get private information, write some academic paper and then disappear. Like, that's not the purpose of this. In fact, um, really what we're trying to do is, as I've said before, create a foundation, right? Something to
Mm-hmm.
build upon. If you ask me, what does it look like as a final product 10 years from now that's impactful? It's having Black men that are trained, Black men from the community that are trained to be, clinical researchers. We talked about this, right? So that not only are they informing what we do as far as priorities. Where do we try and make differences along the experience of prostate cancer, whether it's screening or treatment or surviving with the disease. But then those same men are helping us design studies, putting them together so that we can be effective in having not only impactful studies that actually matter and meet the needs, but also that people are participating because it makes sense to them, right? And so this is really the big vision. This is a very early step. But I think we're really excited that we've seen so much enthusiasm from the men in our community to participate.
Yeah.
And as Dante has said, we're really lucky, right? If this was something that I was doing on my own, things like community check-ins, these are little things, right? About, okay, well, if we're going to be doing folks in Snohomish County that are, Eritrean or Ethiopian, we might need translators, right? Or Somali. So there are all these little components of the research that's really born by the fact that we started out with an intention to be community focused. We have community partners that are involved in our research team right now that are helping us create the agenda. They've helped create the script that Dante is using for interviews. And so all of those little things are really instrumental into what we do. And it's something that we hope we can continue to iterate as we scale larger and larger. I mean, the goal is first to address issues here in our backyard, but we have a vision towards understanding that what's happening here in the greater Puget Sound area is not unique, and it truly is probably not that much different from what's happening in Chicago or Detroit or Cleveland or Atlanta. Sure, the magnitude of some of the social influences might be different, but at the crux of it, as I mentioned to you last time I was here, the outcomes are pretty similar. Black men are more likely to be diagnosed and they're more likely to die from prostate cancer when compared to their counterparts.
And one thing is tremendous is that you're sharing that information back out. A lot of times there's studies that are done, or hey, I want to interview you, and you never hear anything back from it. So building that community and sharing that out is really powerful. You started to talk about some of the stats. Some that you shared last time, Dr. Yaw, were quite alarming, especially here for the Pacific Northwest. But can both of you, Doc and Dante, talk a little bit about how Black men are impacted by prostate cancer? Maybe even talk about what it is. As 2 weeks ago, I got colon cancer and prostate cancer twisted up. So, I think that's important.
Yeah. I mean, I think a lot of men don't understand what their prostate necessarily does, right? Because it's not something that we commonly discuss. Prostate is part of your urinary tract, all right? And this is why when it gets enlarged, you may have difficulty urinating, right? It's the first part of your male urethra. It's a gland which creates a fluid, which is part of your ejaculate, right? And that's really its function in the body. So what happens as men get older, the prostate can enlarge. And as we know, when it comes to cancer, you can have abnormal growth of the smallest parts of any tissue, which is your cells. And that's really what cancer is. Cancer is when those cells grow so rapidly and out of control that they can form a tumor. Those cells can grow and escape sort of that primary site where they're growing. And the reason that it can that it causes issues for human beings is that as it grows, it needs more and more energy, and it needs more and more blood supply, it needs more and more food. And so it really literally eats away at the body, right? And so that overgrowth takes over. In the prostate, we know that prostate cancer is extremely common, right? And that was where we started a couple of weeks ago. 1 in 9 average men in the U.S. is going to experience prostate cancer in their lifetime. 1 in 9, all right? That's a lot of men. It's almost 250,000 new cases a year of prostate cancer in the U.S. And so this is a very common disease, as I mentioned. For Black men, the risk of being diagnosed with prostate cancer in their lifetime is about 1 in 7. There are some studies that suggest it might be lower, but you can see it right away that we have this imbalance in the disease because of a higher risk of acquiring it. Now, when people hear that, the first thing they say is, well, Dr. Nyame, tell me about the biology, or it must be a genetic thing. Well, a lot of studies have been done, and the genetics does not explain away that magnitude of difference. It probably is some genetic component, but it's not enough to explain that big gap in developing the disease. And so we really need to start thinking outside the box about what race in the U.S. really means socially, right? And how that can expose us to different social exposures and environmental risks that might put you at risk, right? So I think last time I talked about, hey, your community might be the one where the interstate gets built right through the middle of your neighborhood, and now you're exposed to environmental pollution because of car traffic, or you might not have access to clean water in your community. We have examples of that. But we talked about social stress, right? What we really don't understand what the physical manifestation of stress really can be. But there's definitely a lot of hypothesizing that's been done around what a high stress environment, whether it's stress due to poor access to food, or just the threat of physical violence. I mean, there's a lot of things that people have postulated, right? Well, so in the U.S., Black men are 70% more likely to be diagnosed with prostate cancer. I gave you that stat of 1 in 7. But what's always really humbling is that the risk of dying from prostate cancer is even higher for Black men. So it's a twofold higher risk. Even here in the Northwest, we see about a 70 or 80% higher risk of dying from prostate cancer for Black men. And so the question really is why. And I think there are a lot of things that are very intuitive when you talk to Black men and their support network, that we all understand that there are certain things that probably lead to this, right? Having access to care, having high quality care. I always talk about that, right? Can you see the best doctor, doctors in town? Do you have access? And then, I mean, the list goes on and on and on and on. But I think that a lot of times when we talk about this, we have a lot of assumptions too. So for instance, I've been guilty of saying this, right? That the reason Black men might not be in things like clinical trials is because of mistrust, distrust. And that, for sure, we understand that there's a component of that that's true, right? But if you ask Black men, and this was done in a survey study by an advocacy group called FIN, if you ask Black men what's stopping them from participating in clinical trials, most of them responded that the number one reason was they were never asked. It was never offered to them, right? So this is why this exercise that we're doing is so crucial, because I think we can look and say, okay, it's probably a little bit of this. It's, we know the societal and the structural issues that impact this, but really getting the the word directly from the men who are experiencing is how we're going to actually understand and prioritize. Okay, maybe we're overemphasizing one thing when we really need to be focused in this area.
Dante, would you add to that? I know that Dr. Yaw talked about folks in the Pacific Northwest being more impacted, and who knows, that could be environmental, there could be so many things. But are there other things that you wanted to add to this discussion around statistics?
Sure. I mean, yeah. I mean, he pretty much summed it up. So basically, the premise is not only do we catch it more, as evidenced by the incident cases, but we are more likely to die from it. And he brings up a very good point when he talks about most of us are not even asked about clinical trials. And this is something that I've heard stories about, how they don't have access to the same clinical trials or the same treatments. There are often times where a lot of providers just assume that we can't afford it, or we're not going to be a part of it. And let's not be, I mean, the truth is the mistrust and distrust is there. There has to be an acknowledgement of historical trauma. But also, you do have to make sure your trials are inclusive. You have to make sure that you ask. And so that's something that we need to consider. And then we always wonder, like, why are African American men, when it comes to this, affected more? And he's right, it's not necessarily a genetic thing, But we also know that where you work, where you live, where you play, and who you are, your race or ethnicity, excuse me, your ethnicity and culture could have an effect on your health. Just is it a fair statement to say that Black people are stressed out in this country? I would say so. I mean, we're stressed out. Look at the social contextual factors of where we are, where we live. We live in more impoverished. Most of us sometimes we live in impoverished neighborhoods, and sometimes it's not as simple as just showing up in the neighborhood and saying y'all need to eat better. Like, what does that mean? Like, so where I grew up, there wasn't a Whole Foods in my neighborhood, so it's not like I can just go up and get all organic food and stuff. There's more to it. There's more nuance to it than that. And so when we are looking at things like the incidence and the mortality rates, you have to take into consideration all the factors that are contributing to that. And, the social determinants of health, the way that there are, let's be honest, systemic and structural racial issues in this country. And we have a system for healthcare that, it's not always, it's inequitable. Not everybody has the same access to care and services as everybody else. And so on top of that, you have a population, African-American men, who are, having worse health outcomes when it comes to prostate cancer as opposed to their white counterparts. And so why is that? And so part of the study is asking the men's questions like, what are your experiences? What are you experiencing? Things like that. And so, but he pretty much sums it up with the statistics. I mean, we're talking about nationally mortality rates over twice as high compared to non-Hispanic white men. I mean, not only that, but, I think the average diagnosis for late stage is around 65, 66 years old. So, what does that mean? Well, that means that we're not getting screened early enough. We are not catching it, being at a higher risk population than we are. Maybe we should start looking to get ourselves screened around 45. Or if you have a family history of cancer or any other medical issues, maybe you should look at getting screened at 40. And so there needs to be a conversation around getting us to screen earlier, to really be pushing PSA testing. I know there's been some pushback or some discussion around PSA testing, but it works. The U.S. Preventive Task Force, I don't know if that grade has changed, but it used to be a grade C, which means it's kind of left up in the air to the provider and the patient to discuss it or whatever, while other screening protocols are grade A and B. And so why can't we move prostate cancer for African American men at least up to a higher grade, to where providers are more proactive in discussing their screening with African American men? So things like that. So yeah, that's what I would add.
Yeah, I really appreciate that. So, what are some things that we can do? So I don't know a lot about cancers, but what I hear are things like, oh, it's late stage or stage 4, and if you just had come in 3 months sooner, or you have 2 weeks to live, or 2 months or 6 months to live, those are the stories that I hear. So, what are some things that we can do so that's not told to us or someone that we love and care about?
Yeah. Let me take a crack at this, because I think this is an important thing, to discuss. Prostate cancer is a highly treatable disease, and not all prostate cancers need treatment. Okay. So why do I say that? Well, we have tools in our armamentarium, if you will, in our backpack, if you will. I like that. Let's use backpack. We have tools in our backpack that work, okay? That because we can catch this disease early by screening, right? But there has to be an awareness, right? You have to understand that you can do something about it. You can take a test, a blood test that can help with early detection. And if you're found to have cancer, that there are a lot of options. And I think there are multiple reasons why that message isn't always resonating out in the community the way that it needs to. But that is something that I'm hoping, as we get information from the community, that we can figure out how to close that knowledge gap of not only, hey, this is something that I should be worrying about. Okay, as a Black male, as I get into my 40s, yeah, I probably should start thinking about, prostate cancer screening. At the very least, the grade C recommendation means that you should have a shared decision with your doctor. Now, the grade C recommendation says at age 55, but that's for the general public. USPSTF, which is the U.S. Preventative Services Task Force. We have bad habits of using these acronyms.
We do.
They recognize that there are higher risk populations, and they state like Black men and men who have family histories, right? But they simply say that there isn't enough data for them to make a strong recommendation for that select group. Now, we are doing research, we hope. I've been really fortunate to be partnered with really talented investigators here at the Fred Hutch, for instance, and we've been able to do some work that hopefully might give some inspiration to think about a recommendation at an earlier age. But at the very least, that grade C recommendation means that as a patient, you should have the right to come to your provider and at least engage in that discussion about screening, right? Say, hey, is this good, right for me? And I would argue, knowing what the statistics are for Black men, especially if you have a strong family history, that that's a conversation that you're entitled to have. You're entitled to go up to your primary care doc and say, hey, when should I get a PSA and how frequently? And, I'm worried about this particular thing for me. And that truthfully should start at probably age 40. I would say no later than 45, at least thinking about getting a test and having that conversation. So, I think there's a lot of work that needs to be done. It's very exciting to have opportunities to talk about starting this work for a variety of reasons. But I can tell you, if you get this diagnosis, and especially if you get this diagnosis because your PSA was abnormal, we're catching this cancer at such an early stage that it's highly curable, all right, highly treatable. I often end up quoting to people, hey, listen, we found your PSA is 7. We found a little bit of prostate cancer. It's likely within your prostate. You have a 1% chance or less of dying from prostate cancer over the next 15 years with treatment. Okay, 1%. And so that's what makes the disparity or this inequity sometimes hard to swallow, is that the time course for the disease seems to be a little bit different for Black men. We don't understand why, but find someone now that come into you with a PSA that's really high. It's detected because maybe they're losing a little bit of weight, or they might have noticed some symptoms. That's usually a time where I don't have as much to offer with regards to cure. Now we can still treat. And we can try and preserve quality of life, and survival can be on the order of years when we talk about prostate cancer, even in the advanced stage. But it's a very different ball game than what we call screen detected, meaning you got blood tests, it was abnormal, and we pursued finding out whether or not you had cancer. So a lot of power that we have, an agency to do something about this disease.
Wow. I want to go a little bit more into that. Now, Pastor Coleman is in the chat, and he says, I think it helps by asking Black men to participate, because I'm making 60 years of age and never was asked to participate in some kind of clinical study. So I think that's you're making the point right there, right? And that's pretty scary. What are potential symptoms that might present, that says, hey, what, maybe there's something going on with my prostate and I need to get checked out?
The most common reason a man will come in for a prostate related issue is that urinary symptoms. And a lot of those are benign. That's usually not cancer related. It's the urgency, it's the frequency, it's the weak stream. And so those are common prostate related things that men may experience as they get older. From a cancer standpoint, as I mentioned to you, when you present with symptoms that are concerning for cancer, those could be things like inability to urinate completely, blood in the urine, bone pain, significant weight loss of appetite. That's usually cancer that is, far advanced, because it has to really get outside of the prostate or grow large enough within the prostate to create symptoms. And usually those are states in which we're talking about stage 3, stage 4 cancer.
Well,
so, again, to your point, I mean, this is a great question that you ask. This isn't something where I recommend that you wait to have symptoms. That's really what I'm getting at, right? That proactive thing is pursuing good health when you feel well, right?
Absolutely.
It's going to your doctor, for a routine annual checkup just to make sure things are good, rather than saying, hey, I'm going to wait until I don't feel good to do something about this.
Absolutely, Doc. We've got a bunch of people in the chat. It's good to see all these Black men that have come to show up and hear this message and be supportive. And I don't see any duplicates of names from 2 weeks ago, so that's awesome.
You'll be put
Uh,
soon.
yeah, no, that's powerful. Now 2 questions. One, well, I guess a question and then a statement. And there's a bunch of people that are in the Zoom and they're ready to ask questions. So I do want to get to the Q&A portion. But you were saying they could have problems with urinating. What about frequency in urinating? Like that was a symptom that I had a concern with. I'm getting older and seems like I'm up all night, need to go to the bathroom. Is that a potential problem with the prostate or?
Yeah, that can definitely be prostate related. It's a good reason to see a doctor, and most of the time, that those are things that can be treated pretty efficiently with medication. And then for those who are not interested in medication, sometimes we do consider things like procedures that can be done in an outpatient setting, or even sometimes in the clinic, that can help relieve blockage that's related to enlarging prostate. And that's a very different condition than a cancer. And that we usually call that benign, meaning that it's not cancer related.
Apologize. We have folks that are getting off work, so they're, they want to
Fair
enjoy
enough.
work. So, you
Yeah.
talk off.
On the base, Karen? No,
Let
no,
me
you hooked up better.
just find out who this is, who's live now. Please mute yourself, folks,
Okay.
if you can, because I actually don't know who that is. Everyone
Make
appears to be
some-
muted. Oh,
I
no.
think it's yeah.
I see it. All right, I got it.
Yeah.
So we're almost to the Q&A. They're chomping at the bit.
Oh yeah.
Chomping at the bit. So proactivity is important, and so I couldn't wait for today, Dr. Yaw. I actually got my PSA done within the last 2 weeks, and I'm at a 1.56.
Ooh,
So it's pretty
that's under mine. I
Good.
beat you.
Good.
Uh,
So I'm glad that you checked it. And the key is the pattern, as we mentioned, right? Because someone asked last time, what is an abnormal PSA? And I said, well, historically we talked about 4, but if you're seeing me in my clinic, I might use 2.5. And some of it has to do with how big your prostate is. So again, as we were talking, there was this understanding that it's sometimes we check a number and we just make sure that it's stable and it's not increasing. So, get one in a year or 2 and just make sure that actually, if I'm believing my own work, get one next year and make sure that it's still good. All right.
Oh, I definitely will. And what's sad and unfortunate is I actually had this blood test was ordered back in May or June.
wow.
And so I have a 6-month checkup. I made it to my next 6-month checkup, and because of the podcast, I asked about it, and the doctor was like, "We put your blood work in 6 months ago. That was on you to get your blood done." So, like,
Good. Well, I'm glad we.
Yeah, that's how I got mine. I had it. They drew my blood, and I was like, "Hey, why y'all at it? Can you go ahead and add this PSA onto it?" So they didn't have to redraw the blood. I was just like, "Well, since you're taking it, go ahead and add this in. Go and throw that in there."
So I do want to open it up for questions, but I had one other question: is what is a prostate exam? Can you describe that for folks that again have no idea? And there's some stigma around it for folks that do, which is
Sure. So because the prostate is part of your urine tract, it sits right above the rectum, okay? And so a good way to take a feel of it, especially the portions which may have a tumor in it, is with the finger exam, right? So we take a gloved finger with a lot of lubrication, and what you're doing is you're just checking the back side of the prostate. So the prostate's like, the back of your hand, and what we're doing in that exam is just making sure we don't feel anything that feels like a rock, that's hard, because if that's there, then that's suspicious for cancer. I would argue, and so would all urologists, that a thorough prostate cancer screening evaluation involves both the blood test and the finger examination. But if you had to hold me down and say, Dr. Nyame, pick one, it's a blood test. Okay. So don't let the fear of the whole examination deter you from getting check number 1. But if you're like, hey, under no circumstance am I going to do the finger test, well, at least get the blood test, because if that's abnormal, I bet your doctor could convince you to do the finger test as part of your evaluation, right?
Yeah.
So That's my message. I don't know if everyone would agree with that, but if I had to have one be done, that would be the blood test. And there's good literature to support that. Especially in 2021, the finger test probably a little bit less important than it was historically.
Gotcha. And again, that the prevention, the quality of life that you talked about by, detecting it early, is so important. So definitely
Absolutely.
advocate for that. How long is so with women? They're encouraged to do self breast exams, right? And then go in and have a
Mammogram.
done by
Mammogram, yeah.
So can a man do that himself and check to see if there's something hard in there? If they feel anything?
It would be challenging to do, and so we don't recommend routine self-examinations like we do for women. Now, for young boys and younger men, it definitely recommend testicular examinations, right? Because testicular cancer is something you can get, and presents usually between age 20 and 40. So if we're talking about screening and cancer screening, that's in my domain. That's something you can easily do, but that's not the case for prostate.
Did you say 20 years old testicle cancer?
20 to 40 years old is really the peak age and range for that. So once we get this study underway, if you want to have me back to talk about young men's health and testicular cancer, we certainly can make time for that.
Yeah, yes, sir. Yes, please. All right, chat. It is time for you to come and ask your questions. If you want to raise your hand, I'll pull you off mute so everyone doesn't all jump in at once. So just raise your hand and I'll pull you off mute for questions for Dr. Yaw and Dante. And as we're waiting for them to come off mute, another thought that I had, Dr. Yaw, is you said when it's detected, it could be treated with medication. And you said something about 1% and 15 years. So does that mean that when you get it, you've got 15 years or?
That's just a statistic to say, look, your chance of surviving 15 or more years with, a localized cancer, meaning detected early with treatment, is 99% from a cancer standpoint, right? So it's just one of these statistics we use that demonstrates that this is highly curable. Now, the cure and the treatments are going to be, in some instances, very invasive, like a surgery or radiation. So it's not necessarily that we have pills that treat prostate cancer in that kind of way.
Gotcha. Okay. And when someone they do have prostate cancer, and let's say it's not mild, it's not benign, they're starting to have symptoms. How does that manifest? What does the body go through? What does that look like?
Yeah, we talked a little bit about that. Like you may have, a lot of difficulty urinating. You might
Blood
have
in the urine.
You might have weight loss, bone pains, pains that are out of proportion to like your common arthritis. It can be in the ribs, it can be in the spine. So there are definitely different manifestations of advanced prostate cancer.
All right, absolutely. Are there any other questions in the chat there? I'm asking the ones that are typed in the chat. So if anyone wants to come off mute and talk, that can be very interesting. Dante, will you let us know, for folks that want to participate in the study, how they can do so?
Sure, absolutely. And so you can participate by going to our website, backpacknetwork.org, or you can reach out to us via email, backpack@uw.edu, and we can just discuss setting up an interview with you or meeting, and we can go from there. It's really that simple. I'll be sure to put that contact information in the chat, but you can reach out through us via email, through our website, or via phone, and then we will contact you back, and we'll work out a scheduled date for us to meet. And like I said, it's just a one-on-one interview. And so I'll be sure to place that information in the chat or pass it along through you, Marwan.
Absolutely.
Yeah, and I just want to reiterate for those that prefer phones, we do have a voicemail. You just call, leave your contact information, and our team will reach out. And that number is 206-616-0474. And I believe is up on the screen right now.
Yep, it's on the screen right now.
Awesome.
So, Kuye, go ahead with your question.
Well, one of the questions that I have is those that have been historically underserved in those marginalized, diverse communities, how are you all reaching out to those communities that primarily has been affected the most by prostate cancer because it's been detected or has never been detected, or and all of those different dynamics?
Okay, well, I can answer that a little bit. So what you're describing is literally my work. So I have been trying to build relationships with the community for the past 2 to 3 years since I moved here. And I think it's important that this movement is a grassroots organization. So what we do, we just do word of mouth. We have patients talk to other patients. They recommend groups. We reach out to community-based organizations who put us in touch with other people. We identify community leaders in certain communities, and we set up meetings with them. And so I just basically, it's a boots on the ground approach for me. I mean, my office, we literally do outreach and engagement for this type of cause. And so we connect with a lot of community-based organizations that have roots in the community. And then we are introduced to different people in community. I serve about 13 different counties in Western Washington. And prior to the pandemic, I was traveling back and forth across the state a lot to meet with people, just shaking hands and just setting up meetings in public health places or in community advisory board meetings, things like that, because it's important to build a relationship with these communities, regardless of whether I have a study going on or not. It's my role. I think it's important because you don't want to just wait for the study to come out and then try to go connect with the communities like, hey, come do this research with us. That's not going to work. What you have to do is be boots on the ground and build a rapport and a relationship with these communities. And then, there are other needs other than, unfortunately, health equity. When I met with Ben Young, who's on our community board here at Backpack, we had a great meeting about how housing equity was a problem, or how social justice issues were a problem, or food deserts were a problem. There are other problems. And so it's good to connect with these people. Just going from county to county, reaching out to community-based organizations is usually one of the best ways. And I work at Hutch, so I have access to a lot of, physicians and doctors and things who also work with these same community-based organizations. So we make it our priority to connect. I mean, me specifically, I work with African American, African descent communities, but I also do a lot of work with indigenous populations. And so it's just a matter of reaching out to these communities, whether it be cold calling, whether it be 6 degrees of separation or whatever. It's really a grassroots movement. So that's one of the ways that I personally do it.
Thank you for that.
Thank you for your question.
Allow us to get your contact so that we can ensure. We just want to ensure that we're getting this information out like tonight.
Sure, absolutely.
We should be packed here on this Zoom to get this information out. Talk about, envision other ways to be able to reach would be a wonderful conversation to have with you all.
Okay. Yeah, I'll definitely share that information. Thank you.
Thank you for bringing that point up. One of the things that we have found challenging as a research team is to engage in a time like this. But, this is why we're so grateful to folks like Marwan, opening his own network and community up to us to connect. I think Dante has hit it all the different ways that we intend to keep reaching out. And as I said earlier, we're hoping that there's a continued relationship, right? More than just a one-time presentation. I've committed to coming on to Marwan's podcast. He wanted me weekly. I said, I'm too busy boss for that. But,
yeah, good luck with that.
But I can make some regular visits. So we definitely look forward to holding up our end of the bargain. And we're so appreciative for your time and commitment today to just hearing us out. That's all I got to say. So excited to connect, and you have all of our team's information on the screen, but we'll also make sure that we reach out.
And and I'll say, again, I appreciate the work that you are doing. And making time for us and reaching across the pond, right? I mean, it's really easy to say, you know what, we'll focus in the greater Seattle area, Tacoma, but coming out to Bremerton and Kitsap County, that's awesome because we could easily be missed.
Nah, I love Bremerton. You know,
really?
Christine. You know, I know Christina. That's my girl, and Dr. Lillian and
Who
Yolanda
said
over
that
there.
they love Bremerton? Who said they love
I go there. There's some great
Dante
food over
talking?
there.
Is that Dante?
There's Dante.
Oh,
Come on.
dang. We gotta talk. He said he loved Bremerton.
I do. I go over there, man. Stop playing. Yeah, Dr. Lillian. She's one of my favorite people. Yolanda over at Kitsap County Public Health. Yep. You know, I got
Okay.
connections.
Okay.
I think it might be like Hawaii. You know, it's a great place to visit, but you might not want to live there. You know, especially
Come on. Now you gotta say, come on. You
I
know,
like to take the ferry. I don't like to drive all the way around though. I hate that. I like to take the ferry. I didn't like going through Tacoma and all that way. Though. I couldn't do it. I didn't like it.
You know, to that point, you know, for me, I didn't expect to learn as much as I have. And then again, I hate procrastination. So, you know, prompting me to go and get my blood work done and find out what my PSA is, which I didn't know what that was 2 weeks ago, is all really important. And what it's also allowed me to do from a selfish standpoint is ask questions that I either had or I didn't know I had or came up through having this discussion. So that's really powerful. And I hope that other Black men that watch this, you know, can say, you know what, well, you know what, that is an opportunity to have that conversation, to share through the study, and maybe, you know, hey, look out for the podcast when Dr. Yaw or Dante come back on and say, you know what, I've got some questions that maybe I just feel more comfortable asking them about, and just getting their, you know, their response or advice on who to go and talk to, who to speak to, or what questions to ask, right? How do you advocate for yourself? I think that a lot of times we don't know how to do that, right? And so these things have to be taught to us, and then we have to be encouraged to do that. So I think that's really important. Are there any other questions in the chat? And Pastor Frankie, Dr. Yaw wants me to pass his information to you, so I will be reaching out to you after this is over to give you that information. And do you want me to share your email, Dr. Yaw? You got it. All right. Well, I see you're off mute, QA. Do you have one more thing to add or a question?
Yes, I just wanted to put you know, a face to the name, because I didn't see him here on the Zoom. You know, I can't see him.
Oh, okay. So what's happening, Dr. Yaw and Dante, is I have Restream. Well, I've got the platform, and then I have Zoom, right? Zoom can have as many people as possible, but I can't make you separate you out if you're on Zoom. So they should let's do a quick exercise. There's a chat. Frankie Coleman, Pastor Coleman says thank you. So I will definitely pass that information on. What I would like everyone to do who is watching live and also in Zoom, please go to YouTube and type in my name, MarwanCameron, and subscribe to the Conduit. And then make sure you hit that bell notification so that you know every time that I go live. You won't miss it. And so, you know, these shows are important. Please do that. Just takes a second and you'll get them all. And I promise I won't always do 4 shows in one day. So it is what it is. Well, Dr. Yaw, Dante, I really appreciate you both coming on. I want to kind of give you the final word, final thought.
I'm gonna let Dante give the final word.
Well, first of all, thanks for having us. I really appreciate it, and the work that you do. And everybody, please go check out backpacknetwork.org. You know, we plan on doing some really great and some really important work, and this just not just for prostate cancer and the Black men in the community, but for the Black community, African American, and other marginalized communities as a whole. My office really supports that work, and so I'm happy to do it. I like to connect with as many people as I can, and so does Yaw. And you know, we'll do our best. And we really thank you for having us. You have all really been great, and thank you as well, Marwan, for having me be a part of this.
It's my honor. You know, I believe in empowering people, and this is one of the greatest ways to do that. And I just wanted to reinforce that too. While this study is focused on Black men. Men, you need to have your prostate checked.
Mhm.
That's important. Men, you need to have your prostate checked. You need a
Absolutely.
40 years old testicle check. You know, running all kinds of things. You know,
Go ahead and cough.
past my 40s, I'm like, oh, I didn't miss that. So
They say, get on in there and get checked out, y'all. Get on in there and get checked out.
Pastor Coleman, 60, he done missed it almost twice.
Mm.
Pastor Coleman's old. Jesus might want his sandals back.
Mm.
Well, Marwan, thank you so much,
Thank you.
man. It's good to see everyone.
Yeah, absolutely. The information is in the chat there for Backpack. Go ahead and reach out 206-616-0474. Go to the website www.backpacknetwork.org or send an email at backpack@uw.edu. They are waiting for your call. And as you know, not only do I want to elevate this study and the work by having them come onto the platform as much as they would like, but for the folks that have appeared today and 2 weeks ago, you all will be receiving $25. So I believe in really supporting the work. And that wasn't something that Backpack asked to do. It's just something that, you know, is real. So for Backpack, for Dante, for Dr. Yaw, for everyone in the Zoom, I am Marwan Cameron. This is The Conduit. We will see you next time.